and even dismissed. So, and the approach and management has evolved over time and really been changing with new data coming in. And we really would love to have a speaker, a very qualified speaker to educate us. And here we are, have Dr. Sophia Yen, and I will let Dr. Yang introduce herself and take us to this very complicated topics.
Hi,
Welcome.
everyone. Thank you so much for having me. I'm not a Wellesley alum, but I'm definitely Asian American, and I went to MIT, so I have lots of friends that went to Wellesley and colleagues and friends in my life. Just some background on me. Grew up in the Bay Area, California. Went to MIT, froze my butt off, and said I would never do East Coast again. And then went to UCSF Medical School, Children's Oakland for pediatrics, back to UCSF for adolescent medicine, what we call sex, drugs, rock and roll, a little acne, some sports medicine. And then to get more degrees in the Bay Area, I got a master's of public health at UC Berkeley, focusing on maternal child health, focusing on obesity. So that's a specialty of mine. And I'm currently a clinical associate professor at Stanford, but that is only for identification purposes. Nothing in this presentation reflects Stanford other than my academic bent. And then about 12 years ago, I was giving a talk to a bunch of physicians. Why don't women take their birth control? And one of the top reasons was didn't have it in their hand. So my friend and I came up with this company to deliver birth control to women's doors. And then we ran ads, free birth control delivery, and 60% of people that responded did not have a prescription. So luckily I'm a doctor and I could write prescriptions. So we added that. And then I hit menopause, and all my friends were like, menopause. And I'm like, yes, I will find the best treatment for me and I will share it with all of you. And so Pandia Health is 100% physicians, and we provide expert birth control and menopause care, peri/menopause care. And I'm going to pull up my slides. Oh, okay. Hold on just a sec. Can't talk and share slides at the same time. Too much for my brain to do. Let me pull up there. Okay, now we're good. Okay, and share here. And yes, I know it's not in presenter mode, but the OCD in me likes to know what slide is coming up next. So hopefully it's good enough. If it's bad, tell me and I will switch it to presenter mode. So, Pandia Health, we are the only women-founded, women-led, doctor-founded, doctor-led asynchronous telemedicine for birth control and perimenopause. I just want to quickly cover asynchronous telemedicine is better than synchronous telemedicine for confidential stuff because patients are more honest about sex. How many sexual partners have you had? Does it hurt when you have sex? When was the last time you had sex? On a questionnaire versus a video or a phone where I just met you. And then you can start care 24/7. You're up at 3 a.m. with hot flashes or night sweats or insomnia. You're like, oh, I need some perimenopause help. You can get online and start the care, and you don't have to miss work. You don't have to drive somewhere, make an appointment, connect at the exact same time with that physician to deal with your health concerns. And then we've seen our competitors with their synchronous video, phone, turn into kind of pill mills where like must see patient every 15 minutes, write a prescription. Whereas because it's asynchronous, whatever you type, we legally have to read or else you could sue us. So you can type whatever you want and we will take care of those concerns. What makes us different is I come from an academic background, and being a woman of color, I realized, if you don't know, that most of medicine is based on 70-kilo white man, and certainly not for birth control, but the way we're taught to write birth control, which will become relevant later when we hit perimenopause treatment, is that here's a pill your teacher likes, and if that doesn't work for all your patients, then have a backup, and beyond that, good luck with that. And I was like, well, that's kind of one size fits all. And as I personally wrote 3,000 birth control prescriptions over 2 years because I was the first doctor on the platform, I took all 40 different birth control pills and ranked them. Most likely make you bleed, least likely make you bleed. Most likely give you zits, least likely give you zits. Most likely give you munchies, least likely give you munchies. and came up with an algorithm based on age, race as a proxy for genetics, because we were seeing a particular side effect in people of Asian and Black descent, and then health history, acne, PCOS, cash versus insurance, ability to drink 8 glasses of water or not. And with that, we use that algorithm on 41,000 patients. 93% of our patients are happy with the first pill prescribed at the 10-week follow-up. And then more importantly, a standard is how many people that are new to the birth control pill are still on it at a year. Standard is 33%. We have 82% retention at a year. And that's because we picked a pill. You don't have any side effects. We deliver it to your door. So a lot more people are more likely to use it than just, here's a pill. Good luck with that. And then 81 net promoter score for any of you all, and marketing is a very good score. And as a Tiger Asian mom, if you looked at the scores of my competitors, you'd be deeply ashamed. On the bottom, you'll see the difference between customized, picking the best birth control for you based on your race as a proxy for genetics, your age, and other factors. We reduce headaches by 94%, nausea by 71%, and breakthrough bleeding by 57%. So if there are any young people in your lives or you that need the birth control pill, then we're very good at picking the best pill. What we will cover today is peri/menopause. So know that those are different entities. Barriers, definitions, hormonal chaos, symptoms. We'll cover HRT, hormone replacement therapy, though just as an aside, the new phrase is menopause hormone therapy or menopause therapy because there are non-hormonal options. Risks and benefits, weight and menopause, because everybody is interested in that a lot. Bone health and exercise tips. Exercises to lower osteoporosis risk and fitness advice for the menopausal transition, and then resources that we generally like. So if you don't know, there's currently 75 million US women that are in perimenopause, which is the years leading up to that final menstrual period plus a year, and then post-menopause. And there's only 4.1 Menopause Society certified practitioners for 75 million US women. So there is an unmet need for sure. And certainly your OB-GYN or internal medicine or family medicine doesn't have to be certified, but certified means that this person read all the latest position papers, read up on the evidence and science, and took a 100-question questionnaire test and passed that test, showing that they know the latest and greatest. And so that is a hassle for doctors to do, but if they've done it, then that's a great thing. And it's not limited just to doctors, nurse practitioners, physician's assistants, and I think others, nutritionists can take it as well. Know that as of right now, there are 0 hours of menopause training required for OB-GYN, family medicine, internal medicine residencies. Know that 90% of people that show up with menopause symptoms don't get the diagnosis of menopause because it's not taught and it's not in the healthcare practitioner's brain. And only 1/3 of those that show up for care actually get the treatment versus just they put their hand on your shoulder and they're like, it's just old age, hashtag suck it up. And I'm hashtag stop sucking it up. If you have these symptoms, we have drugs and science. Please let a provider that knows their stuff make sure you don't suffer. So the lack of expertise leads to poor health outcomes for midlife women, specifically 1 million women going into menopause each year, 2 million women going into perimenopause each year. And if everybody got HRT, we estimate 60% of fractures that happen in those of us that are 50 and above could be avoided with hormone therapy. 50% increased risk of heart disease if you don't treat menopause. 24% increased risk of colon cancer if you don't treat menopause. 21% increased risk of diabetes from untreated menopause. So we could save ourselves a lot of health badness, and we could save our community a ton of healthcare costs. So the definitions, this is very technical, but then you can use these technical stuff to show your doctor you know stuff. FMP is your final menstrual period, and menopause is defined as 12 months after that final menstrual period. So for those of you who haven't entered it, it is a frustrating time, this perimenopause, because your periods are getting weird and you get a period and you're like, is that the last period? And then 3 months later, blip, and you're like, oh, I have to restart the clock because it has to be 12 months after that final menstrual period. So then 6 months goes and you're like, huh? And then another period happens and you're like, ugh, and you got to restart the 12 months. The median age where half people get it below, half people get it above of the final menstrual period is 52.5 in the United States, based on a research study of about 3,000 women, which is not a very big number. We will spend greater than 40% of our lives after menopause, which is that 12-month anniversary of your last period. And greater than 60% of us are going to survive until 80. So that's like 30 years at least, 3 decades. Perimenopause, by definition, don't try to argue, it's the definition. I have so many people on Facebook groups like, I'm in perimenopause. And I'm like, are your periods irregular? Have your periods become fewer? And if not, that is the definition. That's just how we define it. So can't argue that. If your periods are not irregular, or you aren't having fewer periods, or you haven't had a period for the past 2 months or greater, then that is not perimenopause. You have to have irregular periods. Let's say you used to be every 28 days, and now sometimes it's every 28, sometimes it's 21, sometimes it's 35. Okay, that is perimenopause. But if you are every 28 days and you've always been every 28 days, then technically you are not in perimenopause. Not to say maybe your ovaries aren't doing anything weird, but that is the definition of perimenopause. And postmenopause is technically any time after that final menstrual period, or technically after a year after that final menstrual period. And this is per the Menopause Society, which rebranded, if some of you are familiar with the old literature, the North American Menopause Society, but they rebranded. So now it's all the Menopause Society. So to put it visually, if this helps you, the final menstrual period average age is like 51, 52, and then menopause is 1 year after that final menstrual period. And on average, perimenopause lasts about 4 years-ish, so like 47, but certainly ±5 on all of this. So maybe 42. But anybody that's trying to freak you out about perimenopause before 42 is trying to freak you out and trying to make money after on you. So there's a lot of people trying to scare people like, oh, you can get perimenopause in your late 30s. No, on average, perimenopause is 47. I might give you 42, but anything before that is an extreme outlier. And certainly things are possible, 1 in a million, but not standard. And we shouldn't be scaring everybody about this. So early perimenopause, your periods are irregular, greater than or equal to 7 days, sometimes greater than or equal to 7 days intercycle variability. So one cycle is 21 days, one cycle is 28 days, another one ±7 days. Late perimenopause means you haven't had a period for at least 2 months. And then once you hit the 12 months, then you are post-menopause. To illustrate what's going on hormonally, the estrogen is this gray thing here, and the progesterone is this green thing here. And in puberty, our hormones and our fertility years is here. And then perimenopause, it is chaos. And this will come into play when we talk about the optimal treatment for perimenopause, is not putting on estrogen on top of this chaos, but rather flattening it and smoothing it. And then perimenopause, your ovaries are like, I'm done, I'm out of here. And the hormones are flat and smooth, but pretty much nothing. And so we need to add back estrogen and progesterone during that period. So differences in perimenopause duration. The menopause transition can be 2 to 14 years for this perimenopause situation, but the average is 4 to 7 years. It's longer, unfortunately, for Black women than white, and earlier onset, unfortunately, is longer duration. So that's unfortunate for those that get it early. Racial differences, African American women on average start 8.5 months earlier, but after adjusting for a whole bunch of stuff, there was actually no difference. So these may account for the earlier menopause in that population. Hispanic and Native American women earlier. South Asian is 47 versus we talked about 52. East Asian is 50 to 51. and Japanese Americans start later than 52. So given this is W3A, that might be useful information. Early menopause, know that family history of early or premature menopause gives you a 6 to 8 times greater risk of early or premature menopause. So early, if you look on the bottom, is age 40 to 45. Premature is anybody who has their final menstrual period before the age of 40. Other risk factors are smoking. Hopefully, none of y'all are doing that. Underweight, which a lot of Asians often are. History of heart disease, plus minus. If you had one of your ovaries taken out, then it's 1.8 years on average earlier. If you had a hysterectomy and they kept both your ovaries, oddly, it's 1.9 years earlier than if they hadn't. Because when they take out your uterus, sometimes they nick the arteries that feed your ovaries. Lower social, economic, educational attainment doesn't apply because you are all alumni. Early age at first birth of your child, separated, widowed, or divorced, I think mainly from stress, and unemployed also from stress. Risk factors for having menopause late. If you're overweight or obese, if you had a bunch of children, if you have PCOS, if you drink more than one drink per week, or about 3 drinks per week. White and red wine showed the strongest association, but beer is fine. And then if you eat fresh vegetables, then you can have menopause later. Symptoms of peri/menopause. I think lay people and doctors all glob it into one. And so the classic symptoms are, by definition, to be in perimenopause, your periods are whack. But the most important ones, the ones most people know, are vasomotor symptoms, hot flashes, night sweats. The one people maybe don't talk about in polite company, but I think we should talk about because we're women, is vulvovaginal symptoms, painful sex. I call it sandpaper sex, as well as urinary tract infection symptoms. Sleep disturbances. So everybody talks about waking up at 3 a.m. and not being able to go back to sleep. And we don't know if it's hot flashes, night sweats, or micro hot flashes, night sweats triggering that, or just that estrogen and progesterone are calming on the brain. And when you take it away, then it disrupts the brain. And so it doesn't sleep. And then I just had a friend tell me personally, all her only symptom of peri/menopause was all of a sudden she just felt deeply depressed, did not want to live. And I was like, wow. And like, I never think of that when I think of peri/menopause. I get anxiety, I get moodiness, I get maybe some sadness and stuff, but like severe depression. And then when she went on HRT, it all went away. And I was like, ooh, wow, we really need to talk about this, that don't suffer. If something all of a sudden changes, it might be peri/menopause. It might be thyroid, it might be something else, but at least, consider this. It doesn't hurt. Other symptoms often associated with menopause, I totally experience. It's like if you've had pregnancy brain, menopause brain to me is far worse. And I think it's because we are, 50 years old. We're at the top of our game. We're expected to be CEOs, C-suite, performing amazingly. And when you can't come up with a name, you can't remember someone's face, that is deeply embarrassing, right? And people wonder, is she qualified? Blah, blah, blah. But yes, I am qualified. I just have a hard time remembering an exact name or an exact something. It will come to me in 20, 30 minutes. But as CEO, it doesn't look good. Concentration, I think a lot of us who have ADHD tendencies, it comes out during menopause, perimenopause. Joint pain, if you haven't heard, I believe the Japanese and maybe the Chinese have a phrase, it's either the 40 or 50-year-old shoulder, that everybody has frozen shoulder at age 40 or 50. And it totally happened to me. I was just in a parking lot and a slow-mo just fell down. Didn't hurt anything major, but then my shoulder hurt and it couldn't get back to full range of motion for like a month. So if any of this happens to you, please go see a physical therapist, because if it scars down, it's going to be a lot harder to rip and fix it than to stretch it out and fix it right away. Dry eyes. My husband's joke is that everything is dry from head to toe. So my scalp is itchy, my ears are itchy, my eyes are itchy because it's all dry and my skin is dry. So when I walk by something, it rips, it tears, it bruises. This is all everything drying up. And then your vagina dries up like the desert. And so it makes things painful and increases your risk of urinary tract infection. The weight distribution we'll talk about later. There is no one universal menopause syndrome. Each person can have whichever flavor they get, but obviously you'll inherit 50% risk from your mom and potentially 50% from your dad's side of the family. But this is just a list of some of the things you can get. We already hit a lot of these, but increase in facial hair, that one hair that just shows up on your chin that you never had, and you don't know how it happened, it just showed up overnight. And decreased libido, a lot of urinary stuff, ringing of the ears. And yes, I think we hit a lot of these. Like I mentioned, estrogen affects every cell from your hair down to your feet. And that's why I strongly advocate we need to require menopause education in medical school, just 1 hour out of 4 years of medical school, covering something that hits 50% of our population. 60 to 70% will have a symptom that's messing up their life that we can treat with medications. Another 30% will get away scot-free. So it'd be interesting to see how many on this call have gotten away scot-free and how many are part of the 60 to 70% that have not. One thing that has become popular on the media is flooding or heavy menstrual bleeding. People don't talk about this. And so when it happens, it's embarrassing or they don't know you can go see a doctor. Anything that lasts more than a week and bothers you, please see a doctor. Don't suffer. We have drugs and science. I hope you will take this home. I hope you will share this with everyone you know. If you are bleeding longer than a week, please see a doctor. We have drugs and science. So heavy menstrual bleeding is heavy flow. That's 3+ days of it. 1 in 4 people will have heavy menstrual bleeding sometime in your peri/menopause experience. 5%, 1 in 20. So if there's 20 people on this call, which there is, one of y'all is going to have 3+ episodes of heavy menstrual bleeding. And then 1 in, 4 has prolonged menstrual bleeding, so greater than 8 days. Like I said, more than 7 days, please see a doctor. And then again, 1 in 20, one of y'all on this call is going to have 3 or more episodes of prolonged bleeding. The example I give of this, because people like stories, I had a friend before I got into menopause. She told me this after, that she had such severe bleeding that she couldn't visit any of her friends' house for a month because she was afraid if she sat down on their chair or sofa and she'd get up, bleh, she would leave a mark. And she did not want to destroy anyone's furniture of anyone's house that she was visiting. Another woman, high power, traveled to Africa, hadn't had a period in a very long time. All of a sudden, flow like a flooding. And in Africa, doesn't have any menstrual products, doesn't have any doctors that she knows she can go to. So please don't get caught in these situations when we can help prevent and treat. Fatigue, if you ask people in peri/menopause in the past 2 weeks, have you felt tired? 1 out of 3. Worn out, 1 out of 4. And other reasons for fatigue, other than the sleep deprivation interruption that happens with peri/menopause because your hormones are crazy and your brain is adapting. 33% of women aged 19 to 49 have iron deficiency, and only 6% with heavy menstrual bleeding, I talked about before, get care. The #1 cause of anemia and iron deficiency in someone who's bleeding monthly or bleeding irregularly is that bleed. And so I have a TEDx talk called #periodsoptional that you can turn off your periods. And then once we know that you've hit menopause, we can put back the estrogen and progesterone. Palpitations, about 50% of us, some point in peri/menopause, are going to have all of a sudden your heart rate just and it's like a panic attack because you and you're like, am I having a heart attack? And certainly you could be having a heart attack. So please go to the ER if that happens and there's sustained chest pain or anything like that. But just if your heart's racing fast and it disappears quickly, then don't worry too much. But if there's any chest pain or radiating down your neck or whatever, please 911 and go to the ER and take a baby aspirin in case it's a blood clot on the way there. If you have palpitations, you want to track triggers. Obviously, stress, caffeine, dehydration, alcohol can make it worse for people. Hydration, if you're not drinking enough water, and deep breathing, obviously, meditation, or I call it spa music, for 1 to 5 minutes each day is a nice thing. Exercise can just keep you, regular and healthy. And then menopause hormone therapy or hormone therapy can reduce palpitations and calm things down on the cardiac level. So to go back to perimenopause, it is chaos. And when you have estrogen on top of estrogen, then you get tender breasts and weight gain. And also when you add estrogen, I think of estrogen as blocks of potential blood, and then you drop those blocks and you bleed. So if you have estrogen on top of estrogen, you're going to get extra bleeding. When the progesterone drops in the perimenopausal state, then you get irregular bleeding, you get sleep changes, and when the estrogen drops, then you get hot flashes and mood swings. And if any of you want to get really technical, what happens in a normal cycle is you pop out an egg and you have this kind of cycle situation. But in perimenopause, it's like the last gasp for your ovaries, and they're like, I'm just going to pop an egg and then pop another egg. And so then you get estrogen on top of estrogen, and then you get these weird side effects in perimenopause. So perimenopause is chaos, not slowly going down, but chaos. And because of the estrogen stacking, you get painful breasts, worsening migraines, growing fibroids, because the estrogen stimulates the growth of fibroids and endometriosis and adenomyosis if you have any of those, and then risk of endometrial hyperplasia, which is increased risk of cancer. So the treatment of this chaos, rather than adding estrogen on top of high estrogen at times and having those side effects, is to smooth your estrogen and progesterone, turn off the ovary, which is doing crazy stuff, and be like, just take it easy, be calm, and then add synthetic estrogen and progesterone, because until 1 year after that last period, you could get pregnant. There are two peaks of unplanned pregnancy, once in the teenage years and once in the 40s to 50s, because people think, oh, I'm done, I'm in that last thing, there's no chance of pregnancy. So if you don't want to be pregnant, wait, make sure you are covered for pregnancy if you're having heterosexual relations until 1 year after that last period. And so hormonal birth control functions to prevent unplanned pregnancy, but it also functions to have smooth hormones until that final last gasp that you're done. It could be done with the birth control pill. It could be done with a vaginal ring, the NuvaRing, Annovera, that you just put it up yourself. NuvaRing is once a month, Annovera is once a year. The continuous birth control, you just skip that last week of pills. There's a new progesterone-only pill if for some reason you are contraindicated for estrogen. And that one, you just skip the last 4 pills, which are sugar pill. And then you could add continuous estrogen back to that one if you wanted. So if you want more information on skipping your bleeds until that last menstrual period, you can watch my TEDx talk, or if you have young people in your lives that don't like bleeding every single month, then go to pandiahealth.com/periods optional. That's my TEDx talk. So back to estrogen. Estrogen matters. It affects every part of your body, and the changes in estrogen levels cause the peri/menopause symptoms. It is so important to have estrogen for your blood, brain, and bones, bladder, joints, and heart. The effects of estrogen loss, specifically on the genitourinary part, is that it thins the tissue in your vulva, it thins the skin of your vagina. Instead of being able to stretch, you lose your elasticity, you lose the rugae, which without rugae, you can't stretch as much. It narrows the vaginal canal and no longer allows it to distend. If you want to get all geeky biological, it decreases glycogen, it decreases the lactobacilli. The normal pH of a vagina after puberty until menopause is acidic. But with the loss of lactobacilli, then it increases and it becomes basic, and it increases lymphocytes, which are signs of infection, inflammation, and it decreases your secretions and increases pathological vaginal discharge and to explain the increased risk of urinary tract infections. When you take away estrogen, your vagina goes and dries up and stuff. And right above it is your urethra. And your urethra also goes, and so as it dries up, there's a greater chance of urinary tract infection. So by putting estrogen there or systemically such that it gets there, then it opens it up and you don't have the dry vagina and painful sexual relations and increased risk of infection. And you don't have the increased risk of urinary tract infection. The urinary tract infection, I think, takes at least a decade or two to hit. And the example I give is I had a family member at age 70 all of a sudden started having urinary tract infections. And as an adolescent medicine specialist, I was like, oh, you having increased sexual relations? And she was like, no. I was like, okay. And then later, unfortunately, she ended up in the hospital with a urosepsis, which is when the bacteria runs into your blood and could potentially kill you. And so this was before I got into menopause, but then we now learn from the urogynecologist. So this is not a gynecologist, this is not a urologist, this is a gynecologist or urologist who decided to specifically focus on women's urinary tract. They all recommend when you're 52 or above, everybody should throw down some vaginal estrogen. So if you're on systemic estrogen, that covers the vagina 50% of the time, but 50% of the time that's insufficient, and you need to add vaginal estrogen. And anyone of any age can add vaginal estrogen. So another example is that I gave that family member the vaginal estrogen, and now she no longer has urinary tract infections. But I also had a friend whose mother was in an old folks' home and was getting urinary tract infections, and I was like, throw down some vaginal estrogen. He told the director of the medical institution, hey, give her some vaginal estrogen. No more urinary tract infections. And I was like, all y'all at that old folks home owe me because I just saved all of your moms and grandmas urinary tract infections. You're welcome. So make sure anybody 60 and above should definitely, at the very least, do vaginal estrogen to prevent recurrent urinary tract infections. There are local vaginal estrogen and similar medications. So like I mentioned, you can do a cream, you can do an insert. There's a ring that you can put up and it just lasts for 3 months and it just releases local estrogen. There is also one that can do systemic. And then there's one that's technically non-estrogen. It's Osphena, which is a selective estrogen receptor modulator. Improvements within a few weeks, full efficacy in 2 to 3 months, does not increase your risk of endometrial cancer, breast cancer, or heart disease because it's local. It's not systemic getting out there to the rest of your body. Weight gain and menopause. So weight gain at the midlife is mainly related to aging and lifestyle, not hormone therapy. However, changes in body composition and fat distribution are related to menopause. And the example I give is because I went into menopause on continuous hormones. I had the estrogen, I had the progesterone, and I didn't have hot flashes. I didn't have night sweats. But from 1 year to the next, my waist disappeared. And if you know me, 99% of my wardrobe is skirts. And I have developed and cultivated 20 years of gorgeous skirts. And I was like, oh no, am I going to have to throw away all my skirts? Or am I going to have to do some metformin or GLP-1 because I'm an obesity expert? And then I went to see my doctor and my waist disappeared, my cholesterol shot up, and she put her hand on my shoulder and she's like, it's old age. You need to exercise and you need to diet better. And in my head, I'm like, I'm an obesity expert. People wait 6 months to see me. I tell people what to exercise and eat. And nothing had changed from last year to this year. But this is before I got into menopause. And I was like, okay, I guess it's old age. And now I realize that old age is a euphemism for menopause, right? Menopause is what happens in old age. When your body takes away the estrogen, the fat redistributes, specifically, as you see here in this apple picture. They like to talk about apple and pear shapes. I can't get it, but this picture maybe helps. The fat goes to your waist. So your skirts and your pants no longer fit. But as an obesity expert, what's even more scary is that the fat distributes viscerally, which means to your organs. So it goes around your heart and in your liver. And my joke there is it's like foie gras of a human. It's fatty liver. And so I was like, if that's what happens when you take away estrogen, you put the estrogen back because I do not want fatty liver, and I do not want fat around my heart, and I definitely want to wear my skirt. So I switched from the continuous estrogen progesterone on the birth control pill over to the HRT, and my waist came back. And I was like, oh, thank goodness, because I was going to have to do metformin or GLP-1 or something. And definitely, I'm working more on muscle nowadays. That's the new thing. Work on your muscle and not so much the aerobic fitness. But know that taking away the estrogen, this hormonal effect affects this distribution, but also when you take away the estrogen, your arteries no longer dilate and your arteries fill up with LDL, which is the bad cholesterol. And then it also becomes insulin resistant, which then fills up with triglyceride. So again, I was like, if that happens when you take away estrogen, put the estrogen back. I want my arteries to dilate. I don't want LDL and I don't want triglycerides. My doctor did put me on a statin. And just as an aside, once you're on a statin, there's no point coming off because theoretically there's no such thing as too low of cholesterol. They really like to get that sucker down. These are my healthy eating tips in general that I use for my patients for obesity, bariatric surgery, GLP-1, but just works for anyone to be healthy. So this whole, restricted time, restricted eating, fasting, just don't eat from after dinner until breakfast. So if you eat dinner at 6 o'clock and you eat breakfast at 6 a.m., you just pulled a 12-hour fast. And that's what the research shows. You don't have to do this 2 days on, 5 days off, all sorts of every third day, or only a 9-hour eating window. Okay. Just don't eat anything from dinner until breakfast. I was like, who eats something after dinner? And then from the obesity point of view, do not eat, do not sleep or nap within 2 hours of eating. So like you eat a giant, I call it carbo coma. You eat a ton of carb at lunch and then you feel sleepy and you take a nap. Well, what does your body think? Your body's like, oh, she's in hibernation. She ate and she slept. Let's turn this all into fat and let's save this for later. No, okay? And so specific example, I tell a patient, if you get a snack at midnight, you have to stay up till 2 a.m. So at midnight, you got to ask yourself, do I want to stay up 2 more hours or do I want this snack? And so you get the idea. Eat 3 times a day at a minimum. So with GLP-1s or in dieting, you're like, oh, if I skip a meal, then I lose weight. Actually, if you skip a meal, your body's like, you're in starvation. I'm turning down the metabolism, and any extra calories you eat at the next meal, it will turn into fat. Because that's how we have survived as animals, is to survive famine. We have not learned to survive feast. And so anytime you skip a meal, next meal, any extra calories get turned into fat. Once you create a fat cell, it never goes away. So do not create a fat cell to begin with. And so do not skip a meal. Even I tell my GLP-1 patients, this medicine will make you not hungry, but you must eat 3 times a day to signal your body that I have enough food. Do not save fat. Do not go into the saving mode. Just burn the calories, please. The plate model you'll see here, I kind of flip it, but flip it just not turn it. Do not listen to anything that RFK Jr. is saying, because no, 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 no. So half of every meal needs to be fruits and vegetables. And I tell people, if you envision every meal on a plate and you cannot fill half of it with fruits and vegetables, then you leave it blank. But more importantly, that's radical, particularly for Asians. When I see a plate, I usually rice and then I put meat and some vegetable on top, right? But the new paradigm is start with protein. So your salmon, your chicken, your beef and broccoli, whatever meat that you are doing, pork or whatever, and only as much protein do you get rice. And that's like, because I'm pretty sure most of us double the rice to the protein ratio. So only as much protein do you get rice, pasta, bread, tortilla, whatever carb of your choice. And in general, the carb you want brown and crunchy, not white and fluffy. So that I think is a simple one. And then if you're going to do GLP-1 or you're going to do some rapid weight loss or you just want to be healthy in general, 60 grams of protein a day. You don't need the crazy amount of proteins that they're saying out there unless they can show you a randomized clinical trial that shows that's actually useful, which I'd be interested in seeing. and then 60 ounces of water a day and 60 minutes of physical activity a day. And it doesn't have to be 60 minutes altogether. It could be 10 minutes out of every hour. You take a break, you do some jumping jacks, you do some dancing, just anything, or just like while you're on a Zoom, bounce the whole time. My thing is get a yoga ball and just bounce on all your calls and all of your meetings. And that counts as long as you get 60 minutes. Or if you want to be really kind of strict, if it's bedtime and you haven't done your 60 minutes, you don't get to go to bed. Do the 60 minutes and then you go to bed. So, want to cover estrogen. Most prescription HRT, hormone replacement therapy, is bioidentical. So you'll hear people talking about bioidentical. It's really just a marketing term. And what that means is that estrogen is the same as the one you would find in your body. So know that there is bioidentical estrogen patch spray gel that is FDA approved. Know that there's oral and vaginal estrogen that is bioidentical and FDA approved and FDA tested. You do not need pellets and you do not need compounded. Anyone who's trying to sell you pellets, that is not standard of care. Anyone who's trying to sell you compounded, just trying to make more money off you because it costs more money for the pharmacist to compound it. It will expire faster. And because of their expertise, they're going to charge you more to do that situation. And it's not necessarily better than the FDA established levels in treatment out there. There is the key to know that there was the Women's Health Initiative. The results came out in 2002, and that scared all the physicians from prescribing. At the time, it was like 30% of women were getting HRT. As soon as this research study came out, went down to 3%, 1/10 the number of women getting conjugated equine estrogen and HRT. And so when they analyzed the research, finally, 20 years of follow-up, those that were on estrogen only had a decreased risk of breast cancer and decreased risk of death from breast cancer. So now we believe that conjugated equine estrogen actually decreases your risk of breast cancer. And it's the synthetic progesterone that was used in the study that may have accounted for the increased risk of breast cancer that they saw. But again, in the conjugated equine only patients, they had a 22% decreased risk of breast cancer. And of those that got breast cancer, 44% decreased risk of death from breast cancer. So it's not the estrogen, conjugated equine estrogen, causing increased risk of breast cancer. Estrogen, I thought it'd be fun for you all to see the different methods. If you haven't seen it, this is the patch. Look how small it is, how thin it is. That's the twice weekly patch. Once you've tried the twice weekly, if you like thin, I don't think you'll go to the weekly, but there is a weekly. It's just thicker and bigger. There is a gel, there is a spray. These you have to use every single day. And there is a ring that's systemic. You put it in there, it lasts for 3 months. There's the local options that we talked about for preventing vaginal symptoms and urinary tract infections. And there is a local ring that lasts for 3 months and can sustain a stable hormone if that's what you want or need. But know that both these rings are pretty expensive. There is progesterone. And if you have a uterus, and you're using estrogen, you must use progesterone because the estrogen stimulates the lining of the uterus and therefore stimulates fibroids, endometriosis, adenomyosis, but also the lining of the uterus. And without progesterone to calm it down, you increase your risk of endometrial cancer. So if you have a uterus and you're using estrogen, you must have progesterone to counteract. But some people, the number 2 surgery in women, number after C-section is hysterectomy. So if you've had your uterus out, then a doctor may be like, oh, you don't need progesterone because you don't have a uterus and it's only used to counter estrogen. But actually progesterone calms the brain, helps with sleep. And so you may need or want it for sleep. And there are no studies showing increased breast cancer with this bioidentical progesterone versus this old Women's Health Initiative, which used medroxyprogesterone acetate. And then the Women's Health Initiative had conjugated equine estrogen with medroxyprogesterone acetate, had an increased risk of breast cancer to 8 out of 10,000. But I would say that 9,992 women benefited and 8 women had breast cancer. They didn't die from breast cancer. They got breast cancer. And luckily, if we catch it early, most people survive. So the truth about HRT, again, just to hammer it home, the Women's Health Initiative in 2002 took HRT away from 2 decades of women. And HRT is now the gold standard for peri/menopause treatment. It beats any supplement. People will be like, can I take this soybean extract? Can I take ashwagandha? Show me a randomized clinical trial of estrogen versus that. Estrogen works 80, 90%. This stuff, 10, 20, 30% of the time. And then know that placebo, a sugar pill, works 10, 20, 30% of the time. Know that many providers are not up to date on the current research and standard of care for menopause, hormonal therapy, HRT, and see a menopause specialist or a Menopause Society certified provider. Or here's 2 take homes: how to test if your doctor knows their stuff. Ask them, what is the latest treatment for peri/menopause? And if they say the lowest amount of estrogen for the shortest amount of time, that's old stuff. How long can I stay on HRT? Oh, well, just for your symptoms. No. If you talk to any Menopause Society certified practitioner who's a person with a uterus, they're going to be like, you're going to find this patch on my dead body. You're going to have to pry this patch from my dead fingers, because just want you to take home from the biological perspective. At age 52, your body takes away your ovaries and is like, thank you for your service. Thanks for hanging around, growing the next generation. Done with you. And your estrogen, your progesterone goes away. And as I mentioned, all this crazy badness happens. So if we add estrogen, progesterone to that situation, and they're like, oh, well, we can only treat you for 10 years. At 10 years plus 52, 62 years old, I take that away. What's going to happen? All that bad stuff that happened at 52 with the loss is going to happen at 62, unless all of a sudden your body manifests estrogen or manifests progesterone. And that is not biologically plausible. They are working on an artificial ovary to do that, or a way to extend your ovarian life. And that's very interesting, but I don't think that's going to happen within the next 10 years. Benefits and risks, we talked about it. It protects against osteoporosis, heart disease, and possibly dementia. Obviously, if you personally have breast cancer, then it can be definitely contraindicated. And the research is it's safest within 10 years of that final menstrual period. Because imagine I take away the estrogen, your arteries no longer dilate, they fill up with bad cholesterol, and then I give you estrogen, which causes blood clots. What's going to happen? You're going to have a heart attack, a blood clot. So you want to, as soon as you take away the estrogen, put it back before all this stuff gets into your arteries and blocks it all up. So my company, because we're asynchronous telemedicine, but also as an educational point, we can only prescribe for the FDA approved reasons. And as you can see here, there's nothing about cardiac. Luckily, there is something about bone, but we can treat for genitourinary syndrome of menopause, but that is only local estrogen. This blood, brain, and bone benefits are systemic estrogen. However, if someone has hot flashes or night sweats that are moderate to severe affecting their life, then we can treat with HRT, and that can have the side benefit of all these good things over here. And then the last one is at risk for osteoporosis. So as women of color, my joke is we often do not have a leg up in medicine, but a lot of us are lactose intolerant. A lot of us suck at getting calcium and vitamin D. A lot of us have family with osteoporosis. If you invoke any of those things, then you are at risk for osteoporosis and qualify for HRT. So this is the way you can demand HRT from your primary care physician, or definitely from any online company servicing that. So we got 10 minutes left. I will run through these. Osteoporosis and menopause. 1 in 2 women, 1 in 5 men over 50 will have an osteoporotic fracture. The kicker is that osteoporosis is totally preventable. In fact, there's a campaign in the UK called Sticks and Stones, May Break My Bones, blah, blah, blah. Their goal is to eliminate osteoporosis by like 2050 or something like that. And so osteoporosis means decreased bone density, increased bone fragility, higher risk of fractures. When you decrease estrogen, you increase your risk of osteoporosis. And until 30, we're building our bone. And then after that, it's just downhill. And women lose about 10% of their bone mass in the 5 years post-menopause, and it definitely begins in the perimenopausal state. So estrogen is essential for bone health. Estrogen regulates the balance between breakdown and formation of the bone, and as estrogen falls, bone loss accelerates. We already talked about that. We talked about that. HRT, estrogen supplementation, is crucial for mitigating peri/menopause bone loss. Certainly, lifestyle changes. Make sure you're getting enough calcium and vitamin D. Make sure you're doing weight-bearing exercises, and it's not sufficient. I learned trampoline. You have to jump up and down on hard stuff, or some people walk around stomping or weightlifting. That is the pressure on the bones, pulling with the muscles, increasing the stimulation of the bones. Some symptoms of menopause. I saw this in my mom. She and I used to be the exact same height, and we recently took a photo, and there is a 3-inch difference. So height loss, and that is the compression from the bone and life. And then the dowager's hump we've all seen, fractures, back pain, and weakened grip strength is also a sign of just weakened muscles. Preventing bone loss, we talked about calcium, vitamin D, weight-bearing cardio exercises, weight training 2 to 3 times a week, and then DEXA scan, which is a bone density test just to check where you are and where you're going with this situation. The Women's Health Initiative in the estrogen-only arm, by being on the estrogen, they decrease the absolute risk of fractures. 7 out of 10,000 for hip, 7 out of 10,000 for vertebral, which is spine, 24 fewer arm wrist fractures, 53 total fractures from being on the HRT. The DEXA scan is just, there's some radiation, X-ray involved, but if your T-score is greater than -1, that's normal. -1 and -2.5 is osteopenia, and then greater than 2.5 is osteoporosis. They start testing it around menopause, but really people feel it should be at 65, actually, I think is when insurance will cover it. But we, as people born with uteri, should really advocate for perimenopause, or, one baseline before that and then some follow-up. I just love Ruth Bader Ginsburg, and she was working out until the end. So moderate impact, walking, jumping, dancing, strength training, aerobic exercise, and balance training is really important. You can do it just balancing on one leg for 60 seconds while brushing your teeth. Resources that I like, websites, menopause.org is the Menopause Society. There's also the Menopause Foundation. My company, obviously, if you follow us on YouTube, we have a lot of educational information about peri/menopause. We have a new AI initiative called mayapause.com. Maya is AI generated. She's Black, Asian, Latina. She's going to go through all the peri/menopause and then discuss with experts what is the latest and greatest in care. These are some books that I love that cover peri/menopause. And then podcast Overreactive is by 2 OB-GYNs. And then Dr. Louise Newsom in the UK is huge and popular in the UK. Lastly, breast cancer and HRT. As I mentioned, vaginal estrogen is fine after breast cancer. And if you want specifically a directory of physicians that are comfortable treating breast cancer survivors, Dr. Men personally had breast cancer and is a Menopause Society certified practitioner and treats people, but she made a list of a bunch of doctors that do that. Dr. Lisa Larkin is amazing. She co-founded Her Medicine, which is just women's health education. I think they're going to do monthly or every 2-month talks for free, but she has a specific website concentrated on treating women for menopause after surgery called oncomenopause.org. And then lastly, please follow and share on social media, Pandia Health, Pandia Menopause. I'm building on TikTok, maybe Insta, but really just TikTok. And then mayapause.com is the website, but mayapause50 on Instagram and TikTok. So that's that part. I will stop sharing. And we can look at the questions. For all you who attended live, you get priority.
Thank you so much, Dr. Yen. And I'm just going through the questions. And actually, there were some questions being put out